Hi, everyone. Welcome to SimiTree's webinar. We're going to give everybody just a minute to get into the virtual room before we get started. While we're waiting for everybody to join, just a few housekeeping items. I will be sharing the handout in the chat. So if you need that, there'll be a link to the handout here in just a few minutes. If you have any questions, please don't hesitate to use the Q&A. We will answer those questions probably by email or a blog post after the webinar, but we will get back to you. So if you have questions, please use that Q&A. We're really excited to have you join today. I'm Missy Gilliland, the Director of Learning and Development, and joining me today are two of the best experts in the industry. I've got Deb and Laurie here that are going to take you through some of the compliance, home health, and hospice topics. So I'm going to turn it over to Laurie to introduce herself.
Good morning or afternoon here. If you all are like me, most of you are trying to stay warm across the country. I'm Laurie Newlun. I am a senior manager here with SimiTree in our regulatory and compliance and quality department. I have a master's degree in nursing and have been in the hospice palliative care, privacy, and general compliance field for 20 plus years. I appreciate you joining us today. As a part of this presentation, I will be covering those topics related to hospice and general compliance. And I'd like to introduce Deb Grott.
Yep. Hello, everybody, and good afternoon. It is 2 o'clock here on the East Coast. My name is Deb Grott, and I'm the Director for Compliance and Regulatory here at SimiTree. I am a registered nurse by trade. Spent most of my career in the home health world, 25 plus years now, between compliance and regulatory operations. So I'm glad to be here with you today, and I'm excited about what we're going to share. All right, some of the objectives today is we really want to review the current compliance hot topics and the increased scrutiny that's haunting home health and hospice. We do know that is, the increased scrutiny has been very strong since COVID has left us. So that's our hot topic for today. So why are the home health and hospice providers targeted? So home health and hospice benefits are costly, and they continue to increase with the number of Medicare beneficiaries as time goes on. We know the baby boomers and things. So in 2022, Medicare spent approximately $23.9 billion on hospice and $132.9 billion on home health. So you can see that it costs them a lot of money for these beneficiaries to receive the services that we provide every day. And they want to make sure that we're not doing anything that's fraudulent or abusive to the system, because the overpayment situation is real. We want to make sure, they want to make sure that they're protecting their dollars. Next slide, Miss. So areas of government focus currently for home health. Medical necessity and skilled need. This is for all disciplines. This continues to be the hot topic. They want to make sure that what you're providing is skilled. Homebound status, making sure that patient meets the criteria for homebound status to be eligible for home health. Therapy utilization, making sure that you're doing those technical requirements, so your 30-day RFAs and things like that. Technical signatures and dates on the plan of care or 485, making sure that those signatures, if they're electronic, that they're designated electronic. If they're illegible, that you have a current signature attestation form on hand to submit. Your ICD-10 coding and your OASIS, making sure that their documentation matches, the patient looks the same throughout all of the documentation that you provide by all of your clinical staff, that your OASIS doesn't say one thing and your clinical documentation says something else. Face-to-face encounter has always been a hot topic. That's a real technical, making sure that you're getting it from the appropriate provider in the appropriate time frame, and that it's for the reasons that the patient requires home health care. Telehealth continues to be a hot topic, making sure that if you use a telehealth encounter, that it is has both the audio and visual components. And then, of course, the PEPR reports. The PEPR reports, they're looking for any anomalies in those PEPR reports, any outliers, and they want to make sure that there's nothing on those PEPR reports that stand out that they want to look at. Next slide. Laurie.
Yeah, so as you all know, hospice trends around auditing and review many of them have been the same for years. We have seen some new items that have been entered, and since the end of the public health emergency, we've seen an increase in review of the hospice data, with one of the most common areas of denial including changes to the notice of election and the addition of patient notification of hospice non-covered items, services, drugs, which took place in October of 2020. Another area of scrutiny to determine hospice medical necessity and eligibility has been the focus on physician narratives for comparative quantifiable data, medical decline, which would include substantive hospice services. There's been increased payments for DME, pharmacy, et cetera, and anything that should be covered in the hospice benefit being paid outside the hospice benefit. In 2022 fiscal year wage index and quality reporting, the proposed rule published in April 2021, CMS reported that in 2019, the Part D spending for patients who are on hospice reached almost $500 million. And then, as Deb said, the anything that's an outlier has become a risk. So we've had some new items introduced, and we're going to focus a little bit on those and mention the other outliers. The quality of care being our HQRP data, star ratings, all that information has really geared up over the last few years and has become a focus not only for what should be reported and should be publicly available, but also focus for audits that are in place. Eligibility and medical necessity to support 6-month prognosis. If you've had any kind of reviews done lately, you've noticed that that terminology of medical necessity often and is the reason for many denials. For the level of care, we know that we're required to have 4 levels of care in hospice: routine, respite, general inpatient, and continuous home care. GIP, or general inpatient, has been an area of focus for a long time when it comes to auditing. Most patients in hospice are routine care. I will tell you that you need to be paying attention to your continuous home care, as that will be a new area of focus that they will be looking at to ensure that you're offering all 4 levels that are appropriate to service. And then, of course, long length of stay. Now, we have 180 days here mentioned for long length of stay. However, I will tell you that depending on the MAC and what's going on there, and then earlier in 2023, CMS initiated a national site visit to visit every Medicare hospice in the country. They are looking at to make sure you actually are providing services in the area where you are, and the number of days that they're looking at and determining as long length of stay may vary from hospice intermediary to hospice intermediary. Next slide. So these areas of focus that we mentioned are around the notice of election and the items that were added during October of 2020. We've seen that as a part of the TPE process and as a part of the review process, they're looking to ensure that the content that's required as a part of the notice of election and as the hospice addendum, or the patient notification of hospice non-covered items, services, and drugs, are available and are completed and are part of the record. So we must include certain things as a part of that. We've got items like cost sharing. They are looking at our physician narratives. Anything that's outside of these, that's billed as part outside of the hospice Medicare benefit, like Part D for hospice patients, or even the unbundling of equipment and items like that, are being reviewed so that they can determine this extreme amount of money that's being spent for hospice patients outside the benefit. And Deb mentioned that earlier. We know from year to year that continues to go up. And then for the hospice PEPR reports, any outliers, we've seen some changes throughout the years in the information that they're tracking on the PEPR reports, and those are based on areas of concern brought up by various organizations. But we know that not only is an area of concentration, but it's also utilized as a part of the auditing process. Next slide. So for current audits, we're going to talk a little bit about that. Deb, could you explain to us who's looking at this information?
Yes, absolutely. So everybody is probably most familiar with your MAC. So your Medicare administrative contractor, they do medical reviews for both home health and hospice. Most recently or continuing is targeted probe and educate audits. Review choice demonstration for home health. If you're in those states, you're pretty familiar with what review choice demonstration is. We have our UPICs, or our United Program Integrity Contractors. That's where your safeguard services are, your QLarent Integrity Solutions, or your Covenant Bridge. We're seeing a lot of pickup in UPIC audits recently. Within the last 6 months, we're seeing more UPIC audits. The SMERCs, which is the Supplemental Medical Review Contractor, which is Noridian, or the RACs for home health and hospice, it's Performant. And then there are 5 regions nationwide for Performant. We also have the CERTs, which are the comprehensive error rate testing, and that is a federal oversight for the MACs. So that CERT program really checks up on what the MACs are doing in their audit series. Next slide, Miss. Targeted probe and educate. This is by far the most hot topic that we've been going through. I feel like since COVID was kind of put to bed and the waivers went away, that boy, targeted probe and educate is picked up, both in home health and in hospice. So the targeted probe and educate, if you're not familiar with it, you're lucky. I will say that most providers are. MACs, or the medical review program, it was developed by the MACs, and it was for an improper payment reduction strategy. So it's required by CMS for the MACs to carry out, and it is to find improper payments. They analyze your data by your provider numbers. They're looking at your services and beneficiaries. They're looking at historical claim data, patterns and trends, so your high volume costs, your change in frequencies, your outliers. We're seeing a lot of things where we're having focused TPEs for 2 to 6 visits within a 30-day period, and for 11 specific diagnoses. So we're seeing that a lot. They're doing comparative billing reports between state, regional, and national to see how you compare to everyone else. CMS reports and other government reports, such as the OIG and the GAO. They're comparing. So basically, people are talking across government entities to come up with who's going to be next and who's going to be targeted. The new providers who have submitted at least 50 claims are on the horizon to get these TPEs now. So if you are a new provider and you've not received a TPE yet, if you're approaching that 50 claim mark, you're going to be next on the horizon. So don't be surprised if that comes out.
Yeah, I think we also need to mention, Deb, for hospice TPEs, the areas that we talked about of focus for the changes from October 2020 have been the biggest area of focus, and that information has also been relayed to other auditing groups.
Yeah, absolutely. So once that MAC identifies the risk, the claims reviewed is initiated. So basically, they're looking at your high denials, unusual billing patterns, to validate the issue. They are targeting and probing on 20 to 40 claims. Some of them are focused, such as that 2 to 6 visit pattern, or 11 specific diagnoses, or in hospice, it may be for a level of care, such as GIP or long length of stay. They select a sample, and sometimes they can select it if you have a large number of billing practices in your organization. So you bill a large number of claims on a monthly basis. You may have your claims pulled all at one shot. If you are a smaller organization, it may take several months to pull those claim samples, especially if you're on a focused review. So they initially request those records. They'll go through and look at them. You'll submit them just like an ADR, and they will provide you back feedback, whether it's denied or whether it is approved. If it is denied, there is a threshold error and it does vary by MAC. So error tolerances for CGS are 25%, Palmetto is 20%, and NGS is 15%. So we've had a little bit, of issues where clients, we have a hard time understanding that the MACs do not have all of the same error tolerance, but that really is what it is. If you do not meet that error threshold, then you would move on to the next round of TPE. Where the education comes in is once you finish your first round and you fail, they will provide you one-on-one education to go over the reasons for denial. The expectation is that you're going to correct those errors in the next round. And so 45 days from your education date, you can start the next round of TPE. This can go 3 rounds. We have seen some go 4, but it's not many. Most of them go 3 rounds. And if you do not make it through that 3rd round, then you risk doing 100% pre-bill reviews, extrapolation, or even referral to the RAC, so a recovery auditor or another sanctioning body to do additional audits and review. Laurie, do you have anything to add from the hospice side?
I would just say from the hospice side, also be aware that if you are a new provider, that you are subject to a TPE review. And the initial goal of that is to make sure that you're doing things correctly. But just like with home health, you want to be sure that if you've had a failure rate that meets the threshold in the first round, that you get those things corrected and you have established processes within your organization so that you don't advance to other rounds.
Absolutely. So the top denials that we see in home health, number one, and I never understand, is that your records are never submitted. So, I mean, you can't really fight something if your records are not submitted. Your face-to-face requirements are not met, and that's whether it's either not timely or not done by the appropriate provider or not for the reason why the patient was being seen for home health. Your initial certification was missing, incomplete, or invalid. And that means either you didn't have a 485 that was signed, that was submitted, or a plan of care, or even your initial attestation statement regarding your face-to-face was missing or invalid. It didn't match your face-to-face date, etc. Documentation, of course, that doesn't support medical necessity or skill. That's a hot topic right now. They're really looking at those second beneficiary periods. So your second 30 days in a claim period, they want to make sure that you're carrying that skill into that second 30-day period. Documentation to support homebound status. You want to make sure that your physician's documentation and your documentation collaborates as well on that patient, and making sure that discipline to discipline is documenting fairly the same things. You don't want your nurse documenting it one way and your therapist is saying that the patient is independent, because that will bring the question of homebound status. And then, of course, no physician orders for services provided.
For the top denial reasons for hospice, we know that notice of election is invalid or doesn't meet regulatory requirements. That's really the focus that we talked about earlier around the new requirements that took place in October of 2020, ensuring that all those requirements are present and have been met. You also want to make sure that in addition to those missing elements, that everything is done timely, that you have appropriate signatures, that your election dates are specifics, that the patient can elect the start of services after the signature date, but the services may not be started prior to signature date. Then for physician narratives, it has to be completed prior to billing and provides quantifiable comparative data to support decline. That initial verbal certification should be no more than 15 days prior or 2 days after starting services that are written and completed prior to billing. For records not submitted, again, I'm with Deb. That's just really basically not having a process in place within your organization so that the information gets to the right people timely and gets submitted timely. Appropriate or information does not support a terminal prognosis of 6 months or less. This is the information that we're seeing a lot of times referred to as medical necessity. Does the patient meet criteria for services, continue to meet criteria for services? And we're seeing increased many times from month to month to ensure that the patient still meets those requirements. We briefly discussed just a second ago the physician narrative statement. It's either not present or invalid, meaning it doesn't have all the required technical elements. It wasn't done at all, or it doesn't have the quantifiable information there to support the reason the patient can either has hospice services initially or continues to have services. I will say that that's the area that should get increased scrutiny within your organization. If you meet that requirement, many times regulators will stop looking. They know that the patient has met right criteria, but if they can't find it in the physician's narrative or in the face-to-face, then they're going to continue to look, and they're not looking for information to help you support that. So be aware of it. Initial certifications are not done timely. We just talked about the timeframes for that. We had no valid election statements submitted. So that notice of election is very important, making sure it has all the required elements. It was submitted with the request for the claim. Subsequent certifications are done timely from a perspective of a verbal certification and then a written certification to follow up, and that the face-to-face requirements are there. So they're done timely. They correlate in correct timeframes with the physician narrative and the recertification process. So as we continue on, we're going to talk about new hospice fraud prevention measures and survey updates. These are some of the new things that we're seeing from the changes to the Hospice Act, where they're going to request additional information. So let's move to the next slide. So when we talk about fraud prevention measures, as of August 2023, site visits had been conducted of over 7,000 hospices, and nearly 400 were being considered for administrative action. So one of the things that's become increasingly more important is clarity around what hospices are doing, ensuring that they're meeting the requirements, they actually are practicing services, and they're providing appropriate care. And not only is that information available to regulators, but it's available to the general public as well. So when we talk about these site visits, these were really drive-by visits where they went to look to make sure, especially new organizations, were actually in the location where they said they were going to be, and that they were providing those services. And we've had some calls where people say, oh no, somebody drove by and they came in and asked us questions and we don't know what they're there for. Well, this has really always been a part of that initial certification process with Medicare. However, it wasn't used so extensively in the past. We're going to continue to see that used. It's really a way for them to validate. So enhanced oversight we're seeing in specific areas of the country with this check-in process. As of January 1, 2024, new Medicare provider enrollment activities began. This new 36-month rule for transfer of Medicare provider numbers. So we know that there has been an increase in the country of providers who were just basically setting up hospices so that they could sell them off. And they could make money from that. So they're tightening up on that information. These hospices many times never provided real services. They want to know who's involved in the process of providing services there. And so they're looking at making sure that there may be increased survey activity, and also that those provider numbers can't be transferred within the first 36 months. They also wanted to have additional information about the managing employees, including the administrators and the medical directors have to be disclosed. And we've seen increased requirement for criminal background checks, fingerprinting of all those. And then as of 5/1/24, all hospice patients attending physician and hospice physicians must be enrolled in Medicare or file an opt-out with Medicare. They really want to know who the players are and ensure that they're doing things correctly. Next slide. We've also seen that there's some enhanced survey changes. We know that in oversight for states of Arizona, California, Nevada, and Texas, they're starting to do some prepay reviews, which we've never had in hospice in the past for newly enrolled hospices. There's a review of hospice claims following a beneficiary's first 90 days of service. So they're making sure that the patients continue to be appropriate for services. And in the fiscal year 2024 hospice proposed rule, CMS proposed adding hospices to 424-507B, and this would require ordering and certifying physicians, nurse practitioners, and physician assistants to be enrolled or opted out of Medicare program. So as a part of this new survey requirements, as we discussed, there would be increased scrutiny for new hospices. There would be a requirement for hospices to have survey processes in place that happen no less frequently than every 36 months. There could be increased frequency for that depending on how you do in that survey process. There will be new enhancement procedures. So we'll talk a little bit about those in a little bit, and some special focus programs. Surveyors will be well-trained, educated. We will see more continuity and similarities between the accreditation organizations and the state organizations who are doing the survey process, and more scrutiny over anyone who has a condition level deficiency. Surveyor teams may be multidisciplinary. In the past, those have primarily just been nursing services, but now we're going to see a variety, if you have more than one surveyor, a variety of disciplines participating in that process. And our information from our surveys will be posted for public review. Next slide. So these are just some timelines of these proposed changes that are going to happen. This is really not anything we're going to dwell on. Some of these have already taken place. Some of them are in process, and we're starting to see the effects of them. Next slide. So enhanced enforcement remedies. What we see is that if you don't do well in the survey process, we're going to see some civil, monetary, management penalties that are put in place to really get that hospice back on the straight and narrow. So this is going to depend on the extent to which the deficiency poses an immediate jeopardy to public health and safety. The nature, incidence, manner, degree, and duration of deficiencies of noncompliance, and the presence of repeated deficiencies of condition level, and the hospice compliance history generally and specifically rated decided deficiencies. So they're going to be looking back to see how you've done in the past. They could do things like put temporary management in place to oversee the hospice to ensure that they meet requirements. They could start with payment suspension of new patients, civil monetary penalties, directed plan of correction, directed in-service training. It could be termination of your license and continuation of payments. And those can vary depending on what's happening and the length of stay. Next slide. So the civil monetary penalties would not exceed $10,000 per day. They could be dependent over a long length of stay or by single incidents. There's an upper, middle, and lower range, which you'll see a slide on in just a minute, and those are adjusted annually. So that total amount not to exceed will go up each year. Consideration for penalty amounts would be the size of the hospice program, its resources, evidence of self-regulating QAPI systems. So your QAPI process is going to become more important as a part of that. And then there will be an administrative hearing process where you could appeal these findings if you needed to. And then on the next slide, you can kind of see the initial information around these civil monetary penalties and kind of how that happens. And if you'll notice in the upper range, it's up to $10,000 per condition level noncompliance. And that could be for the total number of days since you were last seen. So they will be looking back at your previous survey, or the number of incidences when it occurred. Let's move on to top survey deficiency information. Deb, you want to talk about home health real quick?
Yep, absolutely. So I can tell you that in home health, we haven't seen a large change in what our top deficiencies are for surveys. Number one always seems to be around the content of the plan of care, or the content of the comprehensive assessment where medications are concerned, the plan of care itself, and whether that doesn't contain all the components that it necessarily should have. There's a very specific list of components that plan of care should contain. Infection prevention, infection control, these things have been really with increased scrutiny related to COVID and all of the other things that have been going on. They've always been there. However, with COVID, we've seen them kind of rise up a little bit and be more prominent within the home health deficiency world. Discharge and transfer summaries, the standard is that you have to provide a discharge and transfer summary to the facility to which they're transferring, or to the physicians for whom they're discharging, or the discharge to the patient's physician, so that they're aware of the summaries or the transfer of the patient. So all of those things are not new. Those have gone into, those were gone into effect a few years ago, but we're still seeing them rise up. As far as skilled professionals providing services as ordered in the plan of care, we see this all of the time, or only as ordered by the physician. So we're seeing lots of things around orders. You're not following the plan of care. You're not following the physician's orders. You're providing services that were never ordered in the first place. We see things where Maybe nursing did the start of care, therapy wasn't ordered, there was no therapy evaluation order, but the evaluation for the therapist went on anyway. Promptly alert relevant physician of changes. This is a big thing with patient rights and all the things that goes on. Your physician, that patient's physician has to be involved in the care that the client is receiving. So any changes that go on have to go through that primary physician, certifying physician, so that they're aware. So not a lot of changes in home health for the top survey deficiencies, but I think we've seen some in hospice.
Yeah, so I'm not going to go through and read each of these to you, but I do want you to notice that most of them have to do with plan of care. It's some piece of the plan of care. And I will tell you that we're now seeing a connection between what's being reviewed as part of your survey process and the audit process. So you want to be sure that you're looking those. In addition to the information provided as a part of the Hospice Care Improvement Act, which is all the information we talked about previously, there are recommendations to require hospice agencies to have a corporate compliance plan in place and develop a plan for ethical marketing practices. So you're going to hear a whole lot more about that. We'll be having a full webinar on the development of corporate compliance program, and eyes open for that presentation. And at that time, we'll be going through all the elements required for corporate compliance programs and how to evaluate and establish a compliance program and a plan. And you'll see the integration of those between your hospice plan of care, your QAPI program, and then your corporate compliance plan.
Absolutely. So for us, we really wanted you to make sure that you're aware of all the preventative measures. So as an agency, the smartest thing for you to do for preventative measures is pre-bill audits ahead of any type of billing that you're doing, ADR PACA reviews, annual post-pay audits, annual compliance risk assessments, mock surveys and survey readiness, plan of correction assistance, and appeal assistance. This is something that SimiTree's compliance and regulatory department can help you with. We have many clients that we help annually for a lot of these things. We have many clients that we help on an ongoing basis. We're here for support. So any client, any issue that you may have, bring it to SimiTree and let's see if we can help you with that. Laurie, I know there's some hospice hot topics, that you may want to add to this list, but I think this covers most of what we do on a daily basis.
Yeah, thank you all so much. Please be sure to reach out if we can be of any assistance. I know we ran out of time for questions today. So if you can put your questions in the chat with how to contact you, or you can email Debra at the emails listed here. We'll be glad to get back with you and provide assistance. I'm going to turn it back over to you, Missy.
Absolutely. Thank you so much, Deb and Laurie. Great information. And as Deb and Laurie mentioned, if you have any questions, please don't hesitate to reach out. I know there were some questions asked in the Q&A. We will follow up with you and get you those answers. We'll also be sending out a copy of this recording with the Q&A attached with that with our blog post. So we look forward to seeing you at our next upcoming webinars. Thank you for joining us today. Thank you, Laurie and Deb, for sharing such great information. Have a wonderful day, everyone.
Thank you.
Thank you.